As you might know, March is Colon Cancer Awareness and Prevention Month, and we're fortunate enough to have Renda Hamilton here. She is the Oncology Nurse Navigator and Patient Care Coordinator at the Cancer Life Center with the Medical Center of Central Georgia. And she's been in the healthcare field for over 30 years, but she's been in nursing for 5 years. And she has a kind of a personal testimony as to what led her into the nursing field, right?
I do.
So everybody give a warm round of applause for Renda. Thank you for being here.
Thank you. Thank you. Well, let's do a sound check. Can you hear me at the back table there? Yeah, we had a little technical issue with the microphone because the speakers are so close, so we're just going to wing it. If at any time you can't hear me, please just raise your hand and let me know, okay? I want to thank Mercer for inviting the Speakers Bureau at the Medical Center of Central Georgia for inviting us here. It is Colorectal Cancer Awareness Month, so I'm glad that you're taking time out of your day to learn about colorectal cancer, some of the risk factors, and some things you can do to prevent colorectal cancer. It's a tough subject during lunchtime, so I'll try to be gentle. We really don't get into the nuts and bolts of stool and all that kind of stuff till a little bit later on. So by that time, hopefully you'll have eaten and everything will be okay. Nothing too graphic here. So if at any time you have any questions, this is a pretty informal and small group, so please feel free to go ahead and raise your hand and ask me, okay? I like it to be a two-way street. So this presentation that I'm going to give today, this was a grant that was funded by the American Cancer Society and the Georgia Cancer Coalition. This presentation is targeted towards African Americans because they have a greater incidence of colorectal cancer in the state of Georgia alone, but in Bibb County, we are one of the top 10 counties with the highest incidence of colorectal cancer. So that was why the grant was funded, because we want to get that word out there. But these concepts, the prevention, the risk factors, it applies to everyone, okay? All right, so let's get started. Okay, so our whole goal of this presentation was to increase the screening rates of African Americans in particular, but like I said, anybody over 50, that's when we recommend to get a colorectal cancer screening, your first one, to go ahead and get that, and that was the goal of this presentation. Okay, so what is colorectal cancer? Anybody have any ideas about what exactly it is? Ma'am?
I lost my sister to it.
Did you? Oh, just 41 years old, so that's young. Exactly. She said, if you didn't hear her, that she lost her sister to colorectal cancer, and it started with polyps. So we're going to talk about why that is so important, and that's the whole goal of screening, is to get to see those polyps and to get them removed before they actually become cancerous. Any other ideas about what colorectal cancer actually is? A lot of people don't know what cancer is, so we'll explain that, okay? Okay, first let's talk about where colon cancer starts. This is actually a diagram of the colon and the rectum. And as you can see, the outline in blue, that is the large intestine. The large intestine is about 5 to 7 feet long. You also have a small intestine, but that is about the size of half a football field if you stretched it out. So you're probably thinking, why is that called the small intestine when it's actually bigger than the large one? It's because of the diameter. The large intestine is actually, it has a larger diameter because that's where all the waste products and the stool goes and empties from. Where the small intestine is just churning food, it has a smaller diameter and it doesn't stretch as well. So that's why they're called small and large. But very simplistic, this in the large intestine is where colorectal cancer originates and starts. So you have the ascending colon that starts on the left-hand side, and it cuts across at a right angle into the transverse colon, and then on the right-hand side is the sigmoid colon down into the rectum and the anus. So that's the area that we're talking about. Okay, so exactly what is colorectal cancer? It does arise in the colon and or the rectum. It is abnormal cells within that area, and we want to talk about why it's so important to catch it early. If you catch colorectal cancer early, it can be removed before it has a chance to spread anywhere else. Now, the way that cancer spreads is the abnormal cells actually break off and they get into the lymph system and in the bloodstream, and they circulate and they find other places to nest. Colorectal cancer in particular has a high incidence of spreading to the liver, the bones, and the lungs. Okay, so that's why it's so important to catch it early so it can be treated. Now, let's talk about what cancer is in general, how cancer starts. I hear this all the time that when people are diagnosed with cancer, they're like, how could I have prevented it? What have I done to cause cancer? Well, it's a fact that everyone has cancer cells in their body. You probably don't know that, but you do, because cancer cells are simply abnormal cells. Your body is very smart at recognizing abnormal cells and killing them off. Something happens, there's a mutation in the genes that these abnormal cells, your body forgets how to kill them off, or it's unable to for some reason. These abnormal cells keep dividing and keep dividing and keep dividing until it forms a tumor or a mass. That's simply what cancer is. No matter the type, that's how it starts. It's a mutation in a cell that keeps on dividing abnormally. Okay? Any questions about that? Okay. Okay, so who gets colorectal cancer? It doesn't discriminate. It can be men, women, young, old, everybody is at risk. There are some ethnicities that are at higher risk, and those are in particular African Americans. We don't know why that is, but it is a fact, scientific, that African Americans are at higher risk. Okay, here are some cancer trends and cancer rates among African Americans. It is the third leading cause of cancer overall. African Americans are diagnosed at a younger age than most other ethnicities. They're also at greater risk to die at a younger age from colorectal cancer than other ethnicities. Their survival rate is not as good as other ethnicities. And the latest statistics that we have are from 2009, that there were 16,520 cases of colorectal cancer among African Americans, and 7,000 of those died from colorectal cancer. So that's why it's so important to get an early screening. Okay, some of the risk factors that increase a person's chance of developing cancer. We have two types of risk factors. There are things you cannot change, and there are things that you can change. So give me an example of some things that you cannot change. You can't change heredity, that's one. Any other ideas? Your genetics, you can't change that. You also cannot change growing older. Don't you wish we could? Okay, you were right. Personal or family history of colorectal cancer, you have no influence over that. You are who you are, and you can't change your family. Okay, if you have a personal history of polyps, that puts you at a greater risk for colorectal cancer. Chronic inflammatory bowel disease is another risk factor for colorectal cancer, and what we mean by that is ulcerative colitis or Crohn's disease. Those can put you at a greater risk because your bowel is so inflamed all the time. And of course, growing older, we can't change that. Okay, so let's talk a little bit. I don't want to jump ahead too much. Let's talk about family history a little bit. This presentation is really a 3 to 4 hour presentation, and we have a genetics counselor come in too, but you don't have 2 or 3 or 4 hours. So I'll touch a little bit on family history. You do have a greater incidence and a higher risk of developing colorectal cancer if you have a family history, especially if it's an immediate family member, that is parents, siblings, aunts and uncles. So that puts you at, and she's over here like, heavy sigh. That does put you at higher risk. It just means that you would need to be screened earlier than the age of 50 years old. And ma'am, you said you lost your sister at 41. So actually, they say if you have a family history of colorectal cancer, that you should get your first screening 10 years prior to the age that that person was diagnosed. So your sister was 41, 40?
37 when she was diagnosed, and I'm 4 years older. But as soon as I got her back to Georgia, they did a test on me.
They did a genetic test?
Well, no, I didn't do the genetic test, but I have to go for a lot.
Yeah, for more screening earlier.
I was like 42 when I had my first.
Good. good. And I'm glad to hear that. I'm glad to hear that, because I would have been talking to you offline afterwards that, hey, you know, you need to get screened. Because we know from science and research that, you know, it can run in families. Well, how do you know if there's a genetic mutation in your family line? Well, you can see a genetics professional. Her number is actually on that community benefits little handout. If you have any questions about genetics whatsoever, if you have a strong family history of colorectal cancer, I urge you to call and talk with her, and she will be glad to meet with you. Okay, free of charge, even over the phone. She'll be glad to give you some tips on where you can go forward, okay, if you have a strong family history. Okay, so now another risk factor was a personal history of polyps. So I need to tell you what a polyp is so you know if you have a personal history of polyps. So a polyp is nothing more than an abnormal growth on the inner lining of the large intestine. Now, how do you know you have them? Well, you wouldn't unless you had a test. So that's why it's important. These polyps are actually pre-malignant. It doesn't mean they're cancer if they find them. Hopefully they're not. But it takes like 10 to 15 years for these polyps to actually grow. They're in there a long time. That's why you don't need a screening until you're normally at 50, if you're at average risk. They are just abnormal cells. They can look like a mushroom on a stalk. They can also be very, very flat. That's why it's so important to have a colonoscopy or a screening test that actually looks up inside the colon, because we can tell what kind of polyps they are. The beauty of that is we can remove them before they become cancerous. So polyps are not dangerous in and of themselves, but they are if they stay there for a long time, because it's just constant inflammation. Okay, so it does put you at an increased risk. Other factors that can put you at an increased risk are the size of the polyps and the number of polyps. There are some genetic mutations and genetics diseases, and very long words, and I won't get into that, and this is where I miss my genetic counselor because she goes into that. But there are some conditions where you can have many, like hundreds of polyps. That is a genetic, it's called Lynch syndrome, that you can have, and some of these people that have all of these polyps actually have to have their whole colon removed because it's just too numerous to just take out one or two. They have hundreds. So there are some syndromes where you can have a lot of polyps, but the more polyps you have, the higher risk you are for colorectal cancer. Okay, another risk factor is personal history of chronic inflammatory disease of the colon. Ulcerative colitis and Crohn's disease. These are both autoimmune diseases. Ulcerative colitis is very, very frequent diarrhea. It can be bloody at times, most often it is. And Crohn's disease is another autoimmune disease where, you know, you have episodes of heavy diarrhea, bloating, cramping, and they usually have to be controlled with medication. If you have one of those diseases, you're at higher risk for colorectal cancer. And growing older, of course. Your chance of developing colorectal cancer increases after the age of 50. And that's because we start to wear down as we get older. The colon has been very, very busy, hasn't it? Up until the age of 50. The older we get, the busier it gets, things wear out, our bodies are not as adept at recognizing abnormal cells and killing them off. So that's why the older you are, the higher risk it is. That's why we start screening at 50. And recognize that 90% of people found to have colorectal cancer are over the age of 50. All right, so how can we lower our risk? Okay, these are risk factors that we do have control over and we can change. So obesity, the way you eat, smoking is a big factor, alcohol, we can exercise, and we can change our screening habits. So let's talk about each of these, okay? All right, obesity does equal an increased risk of colorectal cancer. That is because if you're obese, you're not really managing the food that you eat, you're not breaking it down as you should, especially if you're eating a high-fat diet, lots of red meat, lots of trans fat. You know, your body has to do something with that. It doesn't break it down so easy, and it sits in the colon for a long time, especially if you're not eating enough fiber. You have to flush that through because everything that sits in there, your body has to do something with it. So it puts you at increased risk. Smoking is another risk factor. You can see on the screen that statistically 60 to 70% of you're less likely to than smokers to die of colorectal cancer. Now remember, this doesn't mean that if you're a smoker, we'd certainly like for you to quit. But if you're exposed to secondhand smoke, it's just as bad as if you're inhaling from that cigarette. So remove yourself from the area. You are swallowing those cancer-causing agents in those cigarettes, and there are about 1,500 different chemicals in cigarettes, in that cigarette smoke. So you're swallowing that. It puts you at increased risk for colorectal cancer and other cancers as well. Okay, alcohol consumption. We always say drink in moderation. That's 1 drink per day for women and 2 drinks for men. Now, here's a little quiz for you. Which do you think has more alcohol? 1 1/2 ounce of whiskey, an 8-ounce glass of wine, or a 12-ounce can of beer? Which has more alcohol in it? Ma'am? Yes, she's right. Have you come to our other seminars? It's true. All 3 of those have the same content of alcohol. So don't think you're doing yourself any favors by just having that beer or just that glass of wine. They all have the same amount of alcohol. So if you're overdoing it, you're putting yourself at increased risk for not just colorectal cancer, but a lot of other different cancers. Now, when we say drink in moderation, you know, I say 1 drink a day or 2 for if you're a man, but you cannot save those up during the week for Saturday. That would be binge drinking, so yeah.
Why do the men get to drink more than the women?
I think it has to do with body weight. They can just handle more.
Just for a small fella, you just have 1 drink.
Yeah. Yeah, I do. I think it has to do more with body weight and body composition. They have more muscle. Okay, so let's talk about exercise. This is nothing new, especially being part of this program. You all know that you should be exercising at least 30 minutes a day. How many are actually doing that? Good, this is a good group. Barry's doing a good job.
If you're not, I need you to leave.
Yeah. Yeah, at least 30 minutes a day. Now, usually I'm speaking to older people in churches that are older. So this is what I say. You know, 30 minutes does seem like a lot for some people that are very, very busy, but it really isn't. I have trouble getting 30 minutes in. Running here, running there, but I have to set priorities. We all do. But if you can't do 30 minutes at one time, break it up and do 10 minutes here, 10 minutes there. You have a beautiful campus out here. Get out and take a walk, you know, for 10 minutes. After the boss has angered you for some reason, go out and take it out 5 or 10 minutes. It all adds up during the day. So it is important to get moving. This is important especially in colorectal cancer because when you are exercising, when you're moving, guess what's happening to your bowel? It's moving too. Got to stay moving. You're going to lose it if you don't use it, and your bowels too. Has anybody ever had surgery? You don't have to admit it, but if you've ever had surgery, why do they get you up the very next day? Yeah, they need to get things up and awake. The bowel is the last thing to wake up when you have surgery, the very last thing. But also it's to prevent blood clots and it's to get things moving. So we want your bowel to wake up. These are just some of the things: walking, jogging, swimming, dancing. It doesn't matter what you do. The important thing is you're moving. Okay, let's talk about screening and when that should begin. It really should begin at age 50 for those at normal risk. Normal risk is you don't have a strong family history of colorectal cancer. Average risk is you don't have ulcerative colitis or Crohn's disease, and you don't have a history of polyps. That puts you at normal risk. You should start at age 50. Okay. Now, for anyone that has a strong family history, you know, like you two, you need to start earlier. African Americans, we really say that some experts agree that they really should start at age 45 because statistically they do have a higher incidence of it. Speak to your doctor about that, okay, and about your concerns. Okay, why get screened? Just to reduce your risk of cancer. So let's talk about some of the changes that you might look for and might lead you to believe that you need to see your doctor. These are some of the things you should look for. Changes in bowel habits. If you have bloody stool, definitely you should see your doctor. A change in the shape of the stool. What I mean by this is if you have a tumor or a mass in your colon, your stool might change shape. It normally should look like long and longish. Some people have balls of stool. This is when we're getting graphic. Balls of stool. But if your stool suddenly changes caliber, meaning it starts to look pencil thin, that's not a good sign, okay? That might be normal once, maybe twice, but if this starts and goes on for about a week or two and you've really noticed a change, you need to see your doctor. Anytime that your stool changes color, and especially if it changes color like clay colored, when it used to be brown, it used to be blackish, now it's total clay colored, you need to see your doctor, okay? So any of those types of changes. You might also have diarrhea or constipation. Everybody has this every now and then. That's okay. But if you're having diarrhea and it lasts for 2 weeks or more, you need to see the doctor, and the same thing for constipation. Okay, you might have a blockage. Now let's talk about abdominal discomfort is also another sign that you might have colon cancer. You can read up there, gas pains, bloating, fullness, or cramps. We all have this every now and then, right? But when it starts to hang on for 2 weeks, 3 weeks, you're really uncomfortable, you have some swelling, that's not a good sign. You need to go see your doctor. Some of the other symptoms of colorectal cancer can be unexplained weight loss, just bone tired fatigue, not just a little bit, but really you don't feel like doing anything and that's not normal for you. Or if you have nausea and vomiting that hangs on for a little bit too long. Now, unexplained weight loss is actually a cardinal sign of any type of cancer. I see this across the board where people are losing 15, 20 pounds over a 3-month period and they're not even trying. They haven't changed their diet, they're not exercising. They're feeling real good because they're losing weight. But that's not a good thing if you're not trying. Now, why does that happen? It happens because when your body has cancer and there's something wrong, your body is smart enough to know that something is very, very wrong. It's trying to fight off whatever it is, so it's speeding up the metabolism. It can't really do anything about it, but everything speeds up and that's why you lose weight. Okay? Cancer requires a lot of metabolism. Okay, so when should you take action? Like I was saying, anything that hangs on for at least 2 weeks into the 3-week period. Do not wait for 2 weeks if you're bleeding, if you have blood in your stool. You need to go to the doctor sooner than that. But any of those other kind of symptoms that can happen any other time and are fairly normal, but if they're hanging on too long, go see a doctor. Okay, let's talk about some of the colorectal cancer screening tests that are available out there. The first one is a fecal occult blood test. The acronym is FOBT. There is a flexible sigmoidoscopy. We have colonoscopy, double contrast barium enemas, and a digital rectal exam. Now, if you go to the doctor and all they do is a digital rectal exam and smear some of that stool on a card and check it, that's not good enough in and of by itself. You need to have a different screening test as well. So let's talk about each of these. Has anyone ever had a fecal occult blood test? A couple of you? Okay. This actually is just checking for hidden blood in the stool. That's what occult means. It means hidden. Can't see it. You probably don't even know that it's there. But you'll go to the doctor and they'll give you one of these little cards like you see here in this stick and a cup. You know what you're supposed to do in the cup. You can figure that out, right? And then you're just going to use that stick and take a little sample of that stool and smear it on the card. Close the card up and take it back to your doctor. What we do with it after you bring that back is put a chemical onto that drop of stool, and if there's blood present, it'll change color. It reacts with that chemical and it changes a bright color. That lets us know that you might have hidden blood in your stool. You'll have to have an additional test to find out why there's hidden blood in your stool, but it very well could be that you've got some polyps inside the colon and that's where you're bleeding from. Okay? Okay, you can have that done every year. Now, a flex sigmoidoscopy is when they take a very, very thin tube with a camera at the end of it. You'll have to do a bowel prep before you do this. And what I mean by bowel prep is they'll give you some laxatives and a solution that you'll take the night before. And the whole purpose of that is to totally clean out the colon, because we're not going to be able to see anything if we put a camera up there and it's all full of stool. So you have to be cleaned out. I promise that is the worst part of the test, is the bowel prep. Okay, so they put this short, thin, flexible, lighted tube up through the rectum into the colon. It checks for any polyps to see if there's anything there. And the drawback to this particular test is it doesn't look throughout the whole colon. It can only go part way up. A colonoscopy, as you'll see in a couple minutes, actually goes all the way around to the end of the colon, and that's why it's the gold standard of colorectal cancer screening. But you only have to have this every 5 years. It does require a bowel prep, but it is very tolerable. Usually they'll give you a little something to kind of help you relax, but you probably will not be all the way asleep. Okay, but you really shouldn't. It might be a little uncomfortable, but it shouldn't be painful at all. Now, a colonoscopy is the same thing. There's a camera at the end of the endoscope. There's a camera. You will be asleep or at least amnesic when they do this. And that's because we're looking at the whole colon. It only takes about 30 minutes is the average time. You do have to have a bowel prep beforehand so we can see all through the colon. And the beauty of the colonoscopy versus the flex sigmoidoscopy is if we see any polyps during this colonoscopy, we can actually snip them off and send them off to the lab to be tested. You won't feel it. The scissors on the end of that endoscope, the clamps are very, very, very small. You won't have any after effects from it. You won't feel any pain. Okay, that's what people are most scared of, that it's going to hurt. But you'll be so out of it you won't care. And you only need this once every 10 years. It used to be where they would give you fentanyl and Versed, 2 drugs, and you would be very groggy the rest of the day after colonoscopy. But now we use Propofol. And the beauty of Propofol is they can put you to sleep very quickly, but they can also wake you up very quickly, and you don't have that after effect of being very groggy and sleepy the rest of the day. Yeah, the Propofol, yeah, I've had both too, and I like the Propofol a lot better.
You can't drive because they say it's still in your system if you can't stop, but you can do it.
Yeah, I don't like the drugs that make you amnesic, that you really don't remember anything, because your family tends to ask you funny things, and and then they ask you later, you don't remember. So you only have to have a colonoscopy if there are no polyps found, everything is clear. You don't have to have another one for 10 full years. So that's nice. That's why it's the gold standard. Now, a double contrast barium enema. This is an x-ray of the colon. You actually have to have an enema while they're taking pictures. This is not a very pleasant test, but the enema is a white solution that has radioactive particles in it, and they take pictures of your colon. Now, you might ask, well, which test am I going to have? It's very much related to the type of insurance you have, what your doctor recommends. Most doctors will recommend a colonoscopy, but there are some insurances that won't give you a colonoscopy without symptoms, and they'll do this instead. Okay. It's not a very pleasant test, but you will get through it. You'll be awake. It's all going to be fine. But you only have to have it once every 5 to 10 years. All right, and as I said before, the digital rectal exam is when the doctor inserts a gloved finger up into the rectum and they're actually feeling for any type of abnormal growth, anything thick, or any kind of polyps. But you should never use it as your colorectal screening test. You have to have one of the others also. Okay, so fecal occult blood test, you only have to have that every year. A flex sigmoidoscopy every 5. A colonoscopy or a fecal occult blood test and flex sig every 5 years, and a colonoscopy every 10. So why should you get screened? Because if they do find any polyps, and it does, God forbid, if it is cancer, that there's a better response to treatment and you have improved survival if you find it early. And it does prevent colorectal cancer by removing those polyps if you do have them. Okay, so just to wrap it up and summarize what we've said, you need to start screening at age 50 and every 10 years afterwards. So even if you do have a clean colon at the age of 50, at the age of 60, you should be coming back around to get tested again. You need to eat healthy, manage a good weight and a balanced diet, get some exercise and keep things moving. You need to know your family history. If you don't know your family history, you need to start asking, okay? If not for you, for your children, because we're not going to live forever, so you need to capture those things now, because as genetics get smarter and smarter and we're able to test for more cancers and more illnesses, your family history is going to become more and more important to know. Limit your alcohol. Men, max of 2 drinks a day. Women, just 1, and you can't save them up till the end of the week. If you smoke, please quit. If you don't smoke now, then please don't start. Okay? And you need to know your options about screening by speaking with your doctor. All right. All right, are there any questions about anything I've gone over?
I was just wondering how the bowel prep differs between physicians, because I know I've heard, well, they want, like some people say, oh, the Miralax, that's how you do it, Miralax. My mom had
Mm-hmm.
You know, and she said it made her really, really nauseous. And you're right, that was like the worst part of it, was just having to drink all that liquid and then sitting on the pot the rest of the day.
Exactly, and that's an excellent question, and I can tell you that the bowel prep, whatever choice it is of laxative, it is physician preference. There isn't a standardized bowel prep on the market. Some doctors, that stuff is called Go Lightly, and how ironic is that name? You do anything but. You do anything but. Because it's this big gallon jug, and it's true, I want to say it's about 2 liters, and you have to drink it 8 ounces like every 10 minutes. And it's terrible. You're literally in the bathroom with the Go Lightly on the sink because you're not going anywhere else. You're just, might as well take magazines in there and a TV or whatever because you're going to be in there for a while. But it does the trick. It's probably the best thing on the market if you can drink it all and get through it. But some doctors recommend the Miralax, and Miralax is my personal favorite because you can mix it, it dissolves, you can't taste it, you put it in Gatorade and just drink it and you're good to go, but you will go. It works just the same, but it is physician preference. A lot of people complain about that Go Lightly, and people are not as compliant with that Go Lightly because it does make you so nauseous and you're just, you know, you're all dehydrated at the end of it. It'll clean you out for sure. But if you're not going to drink it, then what's the point? And I think doctors have realized that and started to move towards the Miralax and the Dulcolax tablets. So,
That's what I've always had.
yeah.
In that lab, I think my doctor has you do like light meals.
Yeah, just the clear liquids the day before.
Broth, and then, but it's not really that bad. Maybe about 6 hours of not being able to clean anything.
Yeah, it is a lot gentler
I think a lot of people put off having a colon for that.
because of that.
But it's not a lot of cramping or anything like that.
Yeah. I mean, if you're compliant with it and you do what you're supposed to, then the test is good. There are patients that think they can get around it and they don't do the bowel prep like they're supposed to, or they start it too late in the day. And that's not a good idea too, because if you do it too late in the day, guess what's going to happen? When you get there, you're still going. And you're going to go the whole time during the test, and that's not good either. That just makes it kind of ugly for everybody.
They still do the test?
She asked, will they still do the test if you're going? It depends on how much you're going. You know, we can deal with a little bit, you know, of gas and things like that, but if you're really still actually going and pretty good, then we're going to stop the test and have you come back. Okay, ma'am, you were first, and then.
I have a question about the polyps. Now, I know with the colonoscopy, if they find polyps, they'll take them out. What about the
The sigmoidoscopy, flexible sigmoidoscopy, they cannot remove polyps. So if they see any, they will mark them and tattoo them usually with some dye, and then they'll send you for a colonoscopy anyway.
And secondly, another question about the polyps. You said that they can lie very flat.
Yes, ma'am.
And apparently, one was lying flat in my mother when she had it done
Mm-hmm.
many years ago. I think she was in her late 70s. And they snipped it, and she really bled a lot when she got home.
Okay.
And had to go back. I don't remember what repair. She was out of town. My sister took care of her.
Okay.
But is that common?
For it to bleed? Yes, it is. And they can bleed if they're removed by the stalk, if they're those types of polyps, or if they're the flat ones. There's always a danger. I mean, it is inside your colon. It is vascular tissue in there. So there is a chance of bleeding. But the doctor at the end of that endoscope, right next to it, is also a cautery instrument. So cautery, they can burn that real quick and burn those vessels so they will stop bleeding. But that's why you sign a consent. There is a chance that if they have to remove some of those polyps that you might bleed. It doesn't happen very often, but it can, or they can, if they have to go too deep.
She was saying it was painful. I had 10 removed.
Mm-hmm.
I can honestly say I did not know it.
Well, you're just saying with the cautery, they have to burn it? That doesn't,
Yeah, cauterization means burning.
that doesn't hurt?
I've never been cauterized, but you know, anything, if you're sedated enough during the procedure, which most of the time, they know how sedated you are. They can tell by your breathing, your heart rate, you know, just your reaction to things. They can tell if you need a little more sedation. So if they would happen to take a polyp and you say, ouch, yeah, they're going to give you a little more medicine.
I can say that they took 10 and I didn't even know. I didn't know that the doctor told me that. You know,
That they had done all
all
that.
I had to do, I think, was like for 7 days I couldn't
because, yeah, you had that removed. Yeah. Now, I don't want to lead you to believe that with the Versed and the fentanyl, which is what they've used for years and years and years, and some units are still using that. At the hospital, we use Propofol. Downtown on 3rd Street, they use Propofol as well. But some places still use the sedation drugs, you know, fentanyl and Versed. It causes a type of amnesia, but I can tell you from experience, because I've had both, where I did kind of wake up during the Versed and fentanyl, and they were trying to kind of move me at the same time, because when they get up to that right angle, the transverse colon up here, sometimes they have to turn you to be able to get the scope around there, and they were pressing on my abdomen. I totally remember that, but I think I cried out once, but I remember nothing after that. So they probably gave me a little more sedation. So you might remember things, but not really, if that makes sense. You know, it's kind of a foggy type of thing. Okay, go ahead.
When you look at the ingredients on the food we eat for the fiber content,
Yes.
sometimes it looks like soluble, insoluble. What should we look for as far as diet?
You want to look for the insoluble fiber. Insoluble fiber. And why is that? Well, because your bowel is not going to absorb that, and that's what we want, because that's the roughage that keeps things moving. Your bowel has peristalsis. You know, that means movement of the bowel. So it's going to move things through, but you need high fiber to keep things moving through. So if you're not eating enough fiber, you know, your bowel, if it's a slow gut, as we call it, things are just going to sit in there for a long time. They're not moving as fast as they should. We also have a dietitian speak at this 3-hour seminar that we have, and I've learned that if you're going to eat red meat, do not eat any red meat that does not end in loin, because it's way too fat. It sits in your colon, and it just will not, it takes days and days and days for it to move through, because the content is so high. It's very fibrous meat, it's tough, and your body just has a hard time breaking that down. So insoluble fiber.
And how many grams of fiber a day should you shoot for?
25 to 30. 25 to 30 grams of fiber. So anything that you're eating, if you'll look on the label, you can see the fiber content in that, but shoot for 25 to 30. You think that's a lot, but if you really do a little homework on the internet, let's talk about high fiber foods for a minute. Any of your cruciferous vegetables, that's broccoli, any of your green leafy vegetables are very good. Apples, fruit, especially beans. You know, your legumes are very, very good at high fiber. They have about 18 for a half a cup serving of beans. So eat baked beans, bean soup. You know, and people say, well, that gives me gas. Well, they have Gas X and all those other products to kind of help with that. Yeah. Remember how they used to say an apple day keeps the doctor away? That's true. You know, because that has 3 grams of fiber in an apple alone. So I think that I've given you a handout from our dietitian that has some high fiber foods on there, some of the dietary recommendations. And remember too, if you're eating enough fiber every day, you need to follow that with water, because what happens to fiber if you don't drink enough water to move it through? It expands and it becomes a big rock in your gut. So you have to drink a lot of water if you're eating a lot of fiber. The solution to pollution is dilution. How's that? Drink water. Okay, any other questions? Okay, I'm going to hang around for 10-15 minutes afterwards, so if anybody has any one-on-one questions you'd like to ask, I'm more than happy to answer them. And thank you so much for coming today. Thank you.
If you were unable to attend today's presentation on colon cancer awareness, please email me at nave_eb@mercer.edu. Your answer to this 3-part question. Give me 2 symptoms of a potential colon cancer, and give me what age you should get screened if you have no family history or other risk factors. For 7 points. Thank you.